Señoras y
Ladies and gentlemen, good morning. We will begin in 5 minutes, and we would like to please ask you to take your seats here in the plenary. We will begin shortly. Thank you very much.
señores, bom dia.
Good morning, ladies and gentlemen. I would please like to ask you to please take your seats, keep your mobile phones on silence mode. We of the Planet Commission for the Americas on PCH. I would like to invite the moderator, the representing PAHO, Mr. James Fitzgerald. The representative of the World Bank, Mr. Christian Herrera. The head of PHC and Integrated Services of PAHO, Mr. Ernesto Vascolo. The director of PAHO, Mr. Jarbas Barbosa. The Minister of Health of Brazil, Mr. Alexandre Padilha. The Minister of Health of Bolivia, Mrs. Marcela Flores Zambrana. The Minister of Health of St. Vincent and Grenadine, Mr. Daniel Cummings. Madam Minister of Health of Uruguay, Ms. Cristina Lustenberg. And the Chief Editor of Lancet Regional Health Americas, Ms. Thaisa Villa.
Muy buenos días a todos.
Good morning, everyone. Welcome to this our last day of this regional meeting of the Alliance for Primary Health Care in the Americas. We have been organizing this forum for a few high-level panels with the presence of our leaders of public health in the world, in the region, to summarize what we've been discussing in the previous days, the importance of PHC as the base of the health system in order to provide equitable and excellent well-being for the population. We have discussed topics as HR, integration, resume some of these discussions with a little bit more depth from this perspective of the leaders in public health and the other authorities to give these recommendations. So we're going to do this by applying the policies in the countries, and we'll have this conversation right now. First, I would like to make a brief introduction of our representatives. So we've invited Dr. Ernesto Vascolo for a brief presentation and considerations, and then we'll have a dialogue with our ministers and directors of the PAHO. Mr. Ernesto, thank you. The floor is yours.
Thank you. Please, the presentation. So it will be very short, very brief. And before starting, I would like to thank the co-chairs, the co-presidents from the Academy, Adriano, also Marcia Castro, Sarah Bennett, I would like also to thank the leadership of Cristina Herrera and also Nelly Bichat and Natalia Houghton that is also here. It was a process not only of participation but also I would like to highlight the deliberation. We had a representation from different perspectives, from different regions, also from different political and ideological looks, considering that the building of this consensus was not only a technical discussion, but it was a strategy discussion that lasted 2 years of work. I would like to leave the most important message, that is the analysis of the speculation, the scenario of speculation, moderation, the shock with the reduction of from 25 to 50% the coverage on the primary care on health in a period of from 1 to 5 years of recovery and lasting and a lot of death. And what does it mean? It means that the high cost of the inaction obliged people not only to reflect but also to be prepared and to incorporate the resilience as a fundamental pillar in the primary care on health. In other words, we need to overcome this false trade-off to empower the health system and the primary care, or the resilience on the health system. And for sure, there is a synergy on these three perspectives. And I will explain the conceptual milestone and also operational milestone that not necessarily was the result of the first stage. I think that this followed the discussion over the 2 years, and in the middle this has to do with the resilience, this has to do with the preparation, the prevention, with the shock, the alerts, the capacity of response and the recovery, and the process of learning. And this cycle of resilience is considering the primary care, and I mean the three pillars of the primary care. So in this way, recognizing the integrated attention from the public health, considering the aspects that were discussed over these 2 previous days, where we discussed the network of services, the workforce, all of this, and also the empowerment of the population, the social participation. This is another important discussion that we had in this journey, and also the intersectoriality. Each one of these axes should be considered as an input that is fundamental. And what I mean in input that is fundamental, I mean the funding that is fundamental in the health system, but also other inputs and resources that are critical. The digital transformation, the system of information, something that is across to all of that. But also this should be considered in a context. And this means not only to analyze the diversity from our region and our country in terms of social and epidemiology, but also a discussion of how we build the resilience and the health system from the perspective of primary care in an integrated way, and also analyzing the governance and the political context that are linked to the analysis of the health systems and the role from each one of the stakeholders on this process. Thank you.
Thank you very much. Good morning to everyone. Well, first of all, I would like to thank our Bajo colleagues for this great partnership in this work. And I also want to highlight that one of the commissioners was Mr. Sebastian Barro from IDB. So in the context of the alliance, this has also been a very important collaboration. And with all the commissioned, with that I see some of you here present. I would like to please ask to put up my presentation. Okay. So one of the most innovative things that we've had in this commission was to effectively connect the topic of resilience with primary health, and this that is, what does the primary health must do? What must it change? Where must it innovate for to contribute to the resilience of the system, and therefore to the resilience of of health and of the society as a whole, its economy, etc. And I think that's one of the most powerful messages we had. And for that, we had several in-depth discussions, a few very intense discussions on what must be done. And it was really difficult to focus on that. What is primary health care, or what are systems based on primary health care, and what do they have to do in order to contribute to resilience and to generate this synergy of that Ernest mentioned, not only through PHC, but also resilience and vice versa. And so here we have three different areas in their conceptual framework. And we have defined a few strategies, concrete actions that countries must carry out, and of course Mr. and Madam Ministers should consider in order to apply and to integrate as policies in their system. And of course we see countries that are in different levels. A few already have some of these characteristics and others not, or they're facing different levels of development. So the first one is the model of primary health as a service, and how these are two very important areas. Also, the model for primary health that provides services to everyone. And that is something that seemed very relevant to us, and to highlight that we must identify the vulnerable populations. And this should be done on the territorial and local level. And we all know that PHC reaches the local communities. And here it is ideal to be able to identify the most vulnerable populations, vulnerable to the risk of that specific place, because risks may vary among territories and places. Maybe there is a risk for fires or heat waves or epidemics and different vectors. So it varies a lot. So it's very important to have this connection. Of course, the integration of the services and PHC, and PAHO is leading this initiative in the region, and how PHC contributes to this. For example, a country in which this has advanced is in surveillance and epidemiology. But we also have to have the surveillance of other risks, not only epidemiological, but other emergencies of public health. And how can PHC contribute with this in the system? Also, the maintenance of essential services. I think this makes us remember the pandemic, how it interrupted essential services. So that is also something important to have in mind in face of different shocks. And the connection in the network, how PHC maintains services on the whole network. So it is also a very relevant area. The second pillar or component is the participation and empowerment of the community. This is very important because for which we've had many discussions on how to engage the community, how to keep the community active, and with the possibility to really influence with its culture. We know that in our region, the culture is very important and must be taken into account also in this case. And oftentimes communities are key to the whole process, from prevention, preparation, response, and adaptation, the whole cycle of resilience. And it's key that during the emergencies and crises, the first goal we have during an emergency is to keep social peace that people rely and trust on the system, and that they understand that everything will turn out fine in spite of the crisis. So that demands that requires that people rely and trust on the system, and APHC is core on this, so we must work on this. The multi-sectorial actions, how can we engage other sectors? And this is really important because we have other areas that rely on health, and also health on other sectors, so we have to engage both sides. In other words, the participation of the private sector with non-profit and profit private sector, and this was also a discussion that was very important, not only in the health industry, but also outside of the sector, in which we have much collaboration. And in these two scopes, the message is that we must prepare beforehand. We cannot only respond to the crisis when it happens. We cannot improvise in face of a crisis. It's ideal to be prepared beforehand. Data. Everyone here in the commission or our members that are related to research, we know that data is a priority. So we need more and better data. So we have many recommendations on this topic, and environmental considerations that are related to climate change and climate emergencies that all our countries are facing. So we have to give some emphasis on that scope. And lastly, funding. So for a resilient PHC, this is a cross-cutting topic. We need to have financial governance, and for that we need tools that are prepared beforehand in order to facilitate the circulation of resources and funds, and how to improve and the pooling of these resources and the management for these resources to reach where they are needed. And so this has to all be prepared beforehand. And the purchasing procurement mechanism and payment mechanism. So this is how this can be applied in the resilience topic, focusing on PHC and the PHC system, or the health system based on PHC. We also had a discussion on implementation. I will conclude here because we don't have time, but just two things I want to emphasize is that there is a political economy behind all of this. There are things that our leaders, Mr. and Madam Ministers, depend, because the response depends on our leaders and the heads of the system. And we see that during crisis as well. So it's key that you have a very important role, and we have written this down in our report, how all of this affects the implementation. And lastly, this requires monitoring, evaluation, and diagnostics of this scope of this environment. So we propose a way of doing this, again, with information, because information enriches the decision-making process, and you, Mr. and Madam Ministers, need this in order to make better decisions. So I conclude here. Thank you very much, and let's continue our dialogue. Thank you.
Thank you, Christian and Ernesto. So thank you so much, Christian and Ernesto. We invite the exploration of this moment, and this is available on the web, and as an action, the actions from the Alliance, it's important to consider this with a lot of depth. So now I would like to pass the floor to Minister Padilha. Let's resume some topics, right? First of all, I'd like to thank you I would like to thank you for COP that was held in Brazil. Thank you for also all the discussions on the climate change, but also the Commission also was important to talk about the model of attention and so on. In your opinion, Minister, the, is there a topic with more relevance to SUS, that is the One Health System in Brazil, as an integrated and federative system? What would be your recommendations, and in your point of view, what is the best way to have this kind of implementation? First of all, thank you for the partnership with PAHO and a set of other funding agencies. A special thanks for Getúlio Vargas Foundation that is allowing us to have this event being held here, and my gratitude to all of you that are here with us, the local managers, the research institutions, but also the colleagues that came from other countries. I think that the 5 recommendations from the Commission are very important, but I would like to, before talking about the 5 of them, I'd like to mention 2 topics that I think that are fundamental and we should consider with more priority, and they are cross to the 5 recommendations. First of all, to face and to fight against the negationists for denying the help. We must think about the role of the leadership of the institutions and each team of primary care on help on its territory. We must have the units of health in the territory with a capacity of communication to dispute in the environment building values inside the society. It's important to reaffirm the value of the science, the defense of the life, the respect. Otherwise, we wouldn't be able to implement the set of recommendations that are mentioned here, because otherwise we would be here debating this set of recommendations, and we face a debate in the society today that is trying to destroy the set of scientific evidences that are consolidated on the field of health. So in my opinion, this is fundamental, and this is transversal to all the other recommendations. If we do not understand the role of the primary health care as a point of contact with the society and the real world, where people build their values, their visions against or in favor the vaccine or life, and we should have the capacity to have the same level of dispute. We can set resources, we can build some technical handbooks for the teams, some models of organizing the team. Otherwise, we would not have a success on this battle. Brazil has a national program of immunization since the 70s that is supported by PAHO, and it was created before the One Health System in Brazil, SUS, and before existing democracy in Brazil again. Our national program of immunization is older than that, and we suffer our primary health care, our rooms of vaccinations inside the units, the role of the teams. We suffer an attack against this national immunization program. Just to have an idea, in 2022, considering our vaccines in the official calendar of vaccination, no one had 90% of vaccine coverage. And this was before a tradition in our vaccination program in up to 2016. We ended 2025, and fortunately, with all of them above 90%, 19%, some of them reached the optimal goal of 95%. But this is a struggle that is daily. It's very important. For me, this fundamental point the teams of primary health care are close to the churches, the spaces of communication, the spaces of living, and the daily life of the families where you reaffirm or you destroy the defense of the science, the life, and the best practices. So for me, it's fundamental to support our primary health care teams able to play to be part of this dispute, this fight. The other point is the acknowledgement that the climate change crisis is a health crisis. If we do not act immediately to adapt our health systems to be adapted to the climate change in different parts of the continent and also in Brazil, our units of health that we built will be destroyed by the flooding. Our populations, as we see in the Amazon, Brazil, wouldn't be able to reach the health units, and also the medications would not be able to reach them due to the drought that is being bad for the river transport that is important for that places, and also we would have the inputs, the supplies being reduced due to the heat, due to the hurricanes and others. So regarding COP30, I would like to thank PAHO that took the discussions to another level. More than 80 institutions and countries support the action plan Belém to be adapted to the climate change based on COP30. So this is a fundamental agenda that is linked to the 5 recommendations to build resilient health units that is adapted to the climate change, to review the guidelines of standards in our units. So I would like to thank the support from PAHO on this regard, and also to think about the capacity of the teams to be resilient to the tragedies and the impacts on the climate change. Think about protocols, integrating data with the climate information, with the information of health. This, for me, is very, very important. The third recommendation is the commitment, the rational commitment of funding. There's no priority when we think about the government if this is not forecasted in the public budget. This should not be only a speech, but this should be practice as well. We made an effort since 2023 when Lula started his new mandate, and also he revealed the budget of health that was reduced before. So we have a new fiscal milestone in Brazil, and it's important to have a budget for the primary health care, because we have a lot of dispute on this budget, because we all know that the power from the specialized attention on health, considering the interest from the market, from the capture of the public budget for the purchase of equipments, medications, technology, or if we do not protect the budget for primary health care, this will be drained by the demands from the specialized attention, the incorporation of new medications and new technologies. We had an important growth since 2022 up to this year in the budget on the primary health care in Brazil. We went from $7 billion per year in 2022, and we reached almost $13 billion per year in the primary health care this year. And with that, we can increase our team. We went from 42,000 teams of family clinics to more than 55,000 teams for family clinics, 29,000 teams for odontological health, so almost 100,000 teams of primary care on health involving the dentistry help, also some alternative models for different realities as clinic in the street, and this reaffirm the commitment. But the sustainability of this commitment, this is a political dispute that is permanent, together with the institutions that are responsible for the budget in Brazil, the National Congress. But the demand of resources for the specialized demand, this is disputing the resources of the budget in the health area. And the third point that for me is fundamental, that has to do with the recommendations, especially regarding the multi-sectorial acting on the model of integral attention, is to understand, in my opinion, the primary health care not as the first and main entrance door to the health system. For me, this is more than that. For me, the primary health care should be the center of the life production in the territories where they are. And this means to have a more active behavior than being only an entrance door. This means to produce life in the territory where they are. In general, in our region, in Latin America, these are territories that are very vulnerable. In Brazil, these are territories that are daily fighting for the life against violence. The violence against women, against children, the violence against the society as a whole due to the crime, the vulnerable situation on the field of inequality, on the social way. They dispute daily the way of organization of the society on that territory that is building values for the families. So a primary care that is not the open door, that should be ahead the door. We shouldn't have a passive posture to wait for people that are looking for the health system. And this means the intersectorial relation and action with other areas. For example, I do not see the primary health care that is not inside the schools. And I know that there is a resistance from the teams of primary health care, and also from a resistance from the teams from school. I'm here with Professor Jaime, that is the vice director of the public health school. When I was from the ministry before, she supported us to have the national handbook of nutrition for the Brazilian population, and now she's in the commission of Lancet and doing a work very important about the ultra-processed food and the impact on health. So we would not dispute the topic of nutrition if we are not inside the schools, if we are not reaching where people build the environments without having the digital dispute, because this territory is crossed by issues that are outside the territory. So we must have a primary health care that is moving on this direction. Many times we occupy part of our debate regarding the arrangements and the protocols that are important inside the basic unit of health. And sometimes we don't talk about how to act outside the unit of health in the territory. And this is fundamental. This involves the recommendations of social participation, the multi-sectorial action, and the model of integral health that can understand this as fundamental. The fourth point is equity. We are a continent that is very it's that we don't have equity. So this is a characteristic, inequality. So for the smaller and the bigger countries, we must have the motto of primary health care that should be equal considering the diversity of the regions. So the challenge to think about different models for different realities. And I'm sure that one of the biggest challenge and a very important exercise on the primary health care in Brazil is how to think about the indigenous health team will be, and different from a big city as Rio de Janeiro, and having different teams for example, the unit of health here in Botafogo, that many of you went there, some units in the periphery, or in communities where we have violence, or the shift should be different. So we have in Brazil different realities. In the riverbed communities, we have specific models for the riverbed communities. We are launching our specific models for regions in the fishing community that are present outside the Amazon region. And we have the challenge. We have in Brazil today more than 300,000 people that are homeless. So the model of primary care that we call the clinic in the street for these homeless people, the topic about the oral health, sometimes this is considered as a peripheral topic, but this is very important. We should think about models of access, having the teams of oral health there. President Lula is investing a lot in mobile units, and Cristina in Uruguay, we are getting close to the border with the mobile units. And the topic of equity for me is very, very important for the primary health care in our continent, in our region. And lastly, each country has a different reality. In Brazil, we have the reality to be a country with a federative republic with 3 levels of government, and who hires and manages in the daily life the primary healthcare teams are the local governments. It's not the regional, neither the federal government. So it's fundamental in countries, in my opinion, where this is the relation, is how the funding model from the national government is guiding some practices and some arrangements on what is hired by the local government, considering the support from the national government to the local government to on the providing, especially having the professionals with that are graduated. We have an important national program that was supported by PAHO since the beginning. That is the program Mais Médicos, that would be plus doctors. We have almost 28,000 physicians that are spread, that was hired by the national government, and the local governments were not able to hire these professionals only based on the local effort, and also some models of funding that can induct to some practices. For example, now we are with a new model of funding that is based on some KPIs, trying to have a type of compensation for the performance on some KPIs. We are seeing a very positive impact on that, and we must think not only on the volume of resources, but also how these resources can take to some good outcomes in the integral health. This is very important. So I would like to thank not only Chaparro, the recommendations from the Commission, but mainly the interaction that we have with the countries in the region, with the Ministries of Health, and also with the local governments, considering the possibility of our teams to interact, because this exercise of learning with our countries in the region are being fundamental to face the challenges that we have here for the primary health care in our country, and Brazil has a lot to do. So if you allow me, I will show here the map. Don't, it's not to attach any country. Don't worry. It's not a map to attach countries, but then we will have an external presentation. But this is our panel from the National Immunization Program, and we were talking about denying. In 2022, only the BCG vaccine was reaching 90% of the vaccine coverage. In Brazil, over 30 years, more than 30 years, from 74, 75 up to 2016. In 40 years, we had the tradition to have our coverage above 90%. And the denying placed us in this situation. We had the situation that some vaccines had 67% of vaccine coverage only in 2022. So fortunately, the map is changing with a hard work that we are doing. The majority, we overcome 90%, and we had a problem regarding varicella of our primary care. Ladies and gentlemen, to continue now for the panel, empowerment of the governance and the funding as a pillar to strengthen the health systems, we invite the following authorities to the stage. The moderator representing PAHO, Mr. Ernesto Bascolo. The Minister of Health from Chile, Mrs. Jimena Aguilera. The Executive Secretary from the Ministry of Health from Brazil, Mr. Adriano Massuda. The Secretary from the Sanitary State from Spain, Mr. Javier Padilla Bernardes. The Vice Minister of Health from Panama, Mr. Manuel Zambrano. And the Vice Minister of Health from Suriname, Mr. Haas Jandahansin. Well, let's have our last session. We are still waiting Dr. Aguilera, Jimena Aguilera. I don't know if she's outside. So, okay, applauses. Well, thank you, Jimena. So let's start and let's be brief because this is a very important session and we have a short time left, and at the same time, considering the previous session, I would like to summarize that build and to empower and to transform health systems based on primary health care is in a certain way to change the status quo. This is not an easy task. There are some elements linked to programs, to interventions about the services, but in fact there is a component of the system, and considering that part of the debate during these 2 days, this is the session where we will debate 2 dimensions that are key and that we can consider as a facilitator of this transformation process, and that makes a reference to the governance as a fundamental role to lead the Ministries of Health, but also the coordination of the system, and also with a reference to the structure of the organization on the distribution of the roles and how it's defined in a certain way, the rules of the game. So we must think about the health system as an institutional milestone. So when we talk about governance, we must think that the institutional dimension by excellence, and also with an important impact, we have the dimension of funding with the role to have the resources, and also with the assigning the resources. But sometimes the debate, and for us is fundamental, is for what we want this transformation, and in which way with the transformation on the governance and funding will facilitate or not the processes of empowering the health system with the rationale of primary health care. So due to the time that we have, we will have two guiding questions that will be the same one to all the participants. And the first one is regarding considering the experiences from different countries as we have here, in which way the transformation of governance or funding are being part of the agenda of transforming the health system in your countries. If you can provide details of these changes, in which way these changes are being facilitators of a rationale to the primary health care in each context. Jimena, please. Good morning, everyone. First of all, I would like to thank for the invitation to participate on this panel. For us, the primary health care represents the ensuring of ensuring right to the access to health. So it's a human right to have the protection of the health, to have the promotion of health. And talking briefly and answering the question, we have a short time left. Well, the agenda of transformation of the health system will against the status quo, but cannot be a big bang. The agenda of transformation of the system are changes that we will improve considering the previous experiences. In our case, the system of health from Chile, it's visible that 85% of the population in Chile has a public insurance, and 75% of the population is registered in the primary care. So all this percentage has the right to have the free access to the health system. So how did we resolve the primary health care? First, we considered this in the municipal level during the dictatorship, and then this was under the municipality responsibility, and this was a trauma for the sanitary system in Chile without participation. In more than 40 years, we have been learning to work with stakeholders that are very rural, with an authority that was elected, and to work for a system that is ensuring the services of health. And it's important that this topic finally of the municipalization that is improving, and to supply the natural contradiction that the system of the primary care should be decentralized in this traumatic way, and to overcome. So it's a work where we recognize, well, that at that time was designated. Now they are elected. We are talking about dictatorship a lot of years ago. So to work with a democratic authority that knows that among the priorities of the population, health will be also there. So we must respond to this. And in a place as a municipality, that is the natural place of intersectorial work. So when we talk about working with the social determinants of health, where we work effectively to respond to the social determination, to overcome education, the conditions of life, and also to improve the poverty through social support and the offering of jobs, protection. So the municipality is responsible for that in Chile. So since the 80s, this is allowing us to improve and to move forward in a design where we need to work in a local level, when we must recognize the intelligence of the local level. It's not a primary care that is only an open door to the system, but it's a level where we need to develop a sanitary and social intelligence in a central level. I represent a sanitary part of the Ministry of Health, but this really has to do with the working with the participation in our case. After that, there are some changes in the funding and governance of the system. This was the first change, the radical change in the governance of the system. When we had the democracy starting, there was a change in the way of funding the primary care. By the municipalization, the way that they were paid, the professionals were paid changed. And the change in the 90s is compensation per capitation, and to establish a better way to deliver resources to the primary care that promoted the health and the protection of health, and that was the capturing compensated by some index that deliver more resources to the municipalities with more poverty, more rural people, and more rational of elderly people. So the system of funding changed to a system of capturing since the 90s. Then in the 2000 years, we had the gratuity of the primary care. And as of the year 2000, it's for free for all the population. In 2005, we had the ensuring the visits of health. Then we had the transformation on the primary care, because among the problems that we had, we considered the load of the disease and the need of intervention. And inside the main situation in the years 2000, we had the chronic diseases, and it was based to respond to the chronic disease in the primary care for diabetes, hypertension, and it's transforming the system that was organized for the mother-child attention. So this is converted during these 20 years into a system that deliver attention from the physician, with medications, with multi-professional team, physiologists, occupational therapists, social workers, to provide speech, for example, speech therapy, and having multi-professionals to deal with these needs of health that at this moment was the main and most important load of disease. In this context, in our government, and we moved forward with the universalization of the primary care. That is a principle for us. The universalization, it's a value by itself, considering that we have a guarantee that all the Chile people are equal and should have the same access to health and to primary care. Even if regardless if the person wants to have the access, but it's there, it's available. And this was very important considering our agenda of transformation. So in this year, we have increased the funding to the primary health care around 24% in 4 years, and the complete health system was 30% because we need to consider the recovery of the pandemic and the health services. That's why the primary care represents, considering the resources to the health attention, so it's 27% on the Chile budget, and this is very relevant. So this agenda of transformation of the governance and the financial mechanisms, this implies, because all financial mechanisms have problems per capita, but it considers the performance. If you are paying equally, we need to generate a payment on the program of resolution to deliver specific resources and incentivize that some actions would be done really on the primary health care. We need to generate a mechanism of incentives because the funding had the problem. Also, another action that we considered inside the agenda of transformation is the topic of telemedicine to support that. Before we had a digital hospital, we created a rural digital hospital, and we generated satellite connection to different rural points. So the primary care had different types of facilities. So where we have a technician of nurse that was working every time, and now with the access of a rural hospital where we have the physician from Santiago, and we had a place to deliver the medications. So this is part of the innovation that allowed us to improve the resolution capacity. So the primary care in part was done by the family physician, but there was not enough quantity to comply with the primary care. But also we consider some basic specialties, considering the recognition of specialty, and also for other experts that are supporting the primary care, the pediatrics, gynecologists. So we retained them in the primary care and we improved the resolution capacity. So all this modification allowed to have this guarantee to have the use of the resource that is destined to ensure the resolution of problems, and also considering what for us is very relevant, that is the universalization that implies more social cohesion. And this is a value where people feel that there is an authority inside the health sector that can understand people and also that can change the way that they deal with people, generating a situation where a society where we are more and more disconnected. So, for example, in Spain, we boosted a resolution regarding the social connected with the WHO, and the system of health is very valuable to boost this social connection. It's important to support, to promote, or to reduce the problems and the rights that the facilities can be a point of social connect, and this is also important. And the last one that I will mention regarding what was mentioned in the previous panel regarding resilience, that primary care having a territorial base, not only regarding people, but also considering a territorial base that allows that we move forward in our model in integrating the system of information with the systems of social services, with the Ministry of Social Development, and with a population that is old, considering the social sanitary needs. It's very important that this is established inside the territory, and that we can work the resilience, considering the response to the disasters that we have a lot. We have a lot of fires, flooding, earthquake, and considering that the primary care is part of the national system of coordination and response to disaster. So this is part of the resilience for us. The establishment of primary care is a secure point in the community. Last week I was participating in the response to the forest fire in the south of Chile, and one of the points that I saw was the preparation so that the establishment would have the stock of water and electric generators working in the community that was suffering the fire. It's important to see people going there, or they could go to the hospital, and it's important to have at the hospital the primary care as a safe point where you have water, electricity, and this is part of the resilience of the system, the national system, not necessarily to health, because health is not responding only to disaster or pandemic, but it responds to a national system that is coordinated, where health is one of the actors. So health can contribute for the empowering, but also contributing to education to generate a base of security for a response to a disaster. And this is also part of an agenda of transformation, and it has to do to the governance on the primary care that depends on the democratic authority that is part of the government, and in which we fund, we supervise, we guide, technically speaking, but we do not integrate in the biggest system because it's part of the general government.
Thank you very much. A round of applause, please. Honestly, it's very exciting because it is something that we've been talking about, and we talked about in the first session. That is the need to create the understand the transformation processes. And your presentation has been very interesting because it allows us to translate the governance and governance process in this trajectory, giving sense to the measures taken by the previous government. And I'm glad you included resilience, because this is another opportunity for us to acknowledge and thank you because of your experience and what you bring to the table, the relationship between PHC and resilience. But what I want to say is that you were not just the person who motivated this, but you were a fundamental actor in the recent past and has helped the development of the commission. But back to our panel. Now I would like to pass the floor to Mr. Javier Padilla, the State Secretary of Health in Spain, and we would like you to please describe the governance and funding innovation that have favored this PHC model in your country. Thank you very much. It's a great honor to be here. Well, first of all, I would like to explain the funding of the health system in Spain. In Spain, the health system, as of 1999, is not funded by the quotation. However, the funding is done through taxes and taxes and state budgets, and also that's referred to the autonomous communities, which are the regions or provinces. Then they are in charge of providing health systems, health services, and this is unique because it's like the regions receive the money from taxes, but they're not allocated specifically. Each region decides how much of that goes to health, education, or other actions within the scope of its competencies. So in this context, governance has a very relevant role in order to align the ministerial priorities with the decisions from the autonomous communities and regions. I believe that when we're talking about funding, the first question we ask ourselves is, for what? Why? Because oftentimes we talk about figures that we should reach, especially when we're talking about primary health, but from one year to the other, we kind of implement 10% in the total. And so if we do this, it's not efficient. We have to think about how to use the money. So as Minister Padilla said, that PHC is not the entry door of the system. I would add that it's not a place. It's not just one thing. It's a way to provide services in an equitable and accessible way with coordination among levels in a holistic manner. In that way, funding PHC, it should not be for like a place, but for something, for a way of doing things. And that is the starting point. And that leads us to understand that there are differential elements in PHC from other levels of healthcare that makes money go less to PHC. When we have an economic crisis and contingency of budgets, money is cut from PHC easier than other areas. And that is because, first of all, or maybe the only one I could say, is that most of PHC costs is human resources. PHC is about people, and PHC is time, the place, the land, and the professional. So that when you're building a budget, when the cuts have to be made, usually technologies and medication can gather more of the money, more of the attention, and that does not happen in PHC. So in order for us to transcend the political decision making and make PHC attract more budgets, we have to qualify professionals, because if health professionals in PHC and also we have to hire them with contracts. So if they have these contracts, when we have a budgetary cut, you cannot fire them. And the second element is that this centrality of PHC that is present here in our speeches must also be incorporated it must be present in the incorporation of technology. So when we talk about technology, this also must be included when we talk about PHC, because then we'll have more attraction to budgets, because it goes beyond the decision-making practices when distributing funds. And besides all of them, the stabilization of the professionals with contracts and the technology, a few years ago we launched the framework for PHC in 2018, 2019 that has the PHC plan, a national plan, and that enables us to have funding and the decision makers on the same table. That will be the technical staff and the decision makers themselves. And another element that is important is that we were able to agree among all the sectors what are the measures within that PHC plan that will be done by the Ministry of Health. So that is not just going through budgets, but for doing funding through transactions in the autonomous communities. So keeping this financing, the end purpose financing, so then you can pay the professionals, it's done by the civil society and also the communities themselves. So this allows us to have this kind of agreement implying all the actors, and it also allows us to align ministerial priorities through an economic or funding incentive and the autonomous communities. We always say that promoting health should be done through what is socially needed or favoring. So we should do this. We have to do what the communities want and through what the ministry also wants. So it's a very decentralized system. Both Spain and Germany are the both countries that have a more decentralized governance in Europe in the health system. So we have 6 items that I believe are key and relevant. The first is to elevate the political priority within the Ministry of Health, because it ministry in the ministry the problem is that the governance structures and leadership and execution in PHC were always included in other instances. So we took the office of PHC and we elevated it to respond directly to the Health Secretariat. That was the first element to trying to give more political importance to PHC. The second element is that if PHC is not a place but a way of doing things, we're trying to align the values of PHC with the actions that are implemented. And one of the examples that I'm proud of is that recently we published a report written by the WHO for Europe with Melita Jacobi and by the European Observatory of Health Systems on how could we promote longitudinality, and in order for this idea of longitudinality to improve the population's health could also be done today, because in the 80s and 90s when the structure was created and people thought people having the same job for their whole life was something normal. Now we have a different situation. We know that people do not have long-lasting jobs. People don't think like that anyway, don't want that. So how can we align this? So in the document published, we have different measures. One of them is regarding funding. So if we want people to stay, we need to pay them for that. And if we want them to stay in the same job, we have to pay. The second, most important, is that to spend more, you have to be able to do so. You need to have spending structures. That's not very attractive because when you talk to the population, that you have reinforced the administrative structures in order to be able to have accountability and be able to spend, it's nothing that is not so attractive. But for us, it is essential. We have to promote that the different scopes have a better strengthening of the administrative and managerial structures. That is key. Another element is the bilaterality between and the partnership between the health and finance ministries. We have started this in other scopes, not PHC, but it's also related to PHC, which is the pharmaceutical area. We have established work groups in all areas and in all the regions between people from finance and health ministry, so that the issue is understood by both scopes, and for the accountability is on the shoulders not only of the Ministry of Health, but also on the Ministry of Finance. The fifth element is to think that we must have PHC in all our policies. If we're talking about digital transformation or climate change, PHC must be included. So the digital health in our system, one of our essential plans is for digital transformation for PHC with digitalized documents and information. And lastly, we are working with the regions on an agreement with all the autonomous communities to link the variations in PHC with the variations in spending in the whole health system. So we cannot have an increase of spending including just PHC or diluting. We need to have the increase in spending in the whole health system must also be reflected in PHC. So those were my reflections. Thank you very much. Thank you very much. That was very useful information. Not only your presence, Javier, is very useful, but the possibility to exchange lessons learned, and as you will see in the previous session, and now here we are continuing to dialogue and thinking about what PHC is. In each case, it's not only related to creatively a definition, but how does that translate in each context, this view we have on PHC. And for even beyond what you said, your description was very rich, articulating all governance innovations and funding in a very integrated way. the context of decentralization that for us is very important, not only in Brazil, in Argentina, or Mexico, but even Colombia and many other countries in Latin America, in which we need to better structure those lessons learned, analyzing these implications of governance and funding in these contexts, but particularly in why or for what and how do we strengthen PHC. Dr. Adriano Massuda, Executive Secretary of the Ministry of Health of Brazil. The floor is yours, and in the same line, if maybe you can help us with a few of your own remarks. Thank you. Good morning. Good morning, Ernesto. Good morning, my panel colleagues. First of all, I would like to reinforce that it's a great satisfaction to be here. We hope that this alliance is strengthened and that we have more events like this one more often, so that we have the opportunity to exchange ideas and experiences and put the light on this global challenge that is to build strong healthcare systems in countries with so many inequalities as our countries in the region. In Brazil, we have a 35-year experience of the implementation of the SUS, the Universal Healthcare System. Last year, we published a law in September, and it was regulated, expanding the primary health care that was done with the advancements and contingencies of building a healthcare system that is universal, comprehensive, decentralized, with strong social participation in a continental country that has so many regional differences. Throughout these years, it is important to note these advancements. We are very proud of them. We are very proud of the Brazilian PHC. It has a very innovative model from the point of view of its concept, its organization, its primary health care that was built along these 35 years with incremental changes, but also we went through setback times. We had very important milestones of worsening and bad impacts of the healthcare system. The minister showed the vaccination rates. If you reduce the coverage of vaccination, everything else gets worse. It's a key indicator. And today we're going through this experience of rebuilding since the President Lula came to power once again, to make a universal and comprehensive system. However, PHC was a strategy that was used in order to expand access, and that was very positive and successful in associating the building of the family health model we had three elements. One was for the shift in the model, the reform of the health system that enabled the implementation of the SUS system was not only part of the logic of the system, but it was a shift in understanding and doing health. It's making some criticism to the traditional way things were done in health, and from this criticism, we built a new model, thinking the comprehensiveness of health not only as access to technology, but also understanding the individual and the family within their context, psycho and social context, and thinking health within this production context as well. And this family health model was developed based on different experience of what was possible to do in Brazil. For example, community health and the community health agents, the experience of nursing, who carried out public health projects in a context with references from popular education, Mr. Paulo Freire. And these were projects that gave us this baseline for the change in the model of production and care, aligning the clinic and family health, creating this multi-professional team, organizing care for a specific population in a specific territory. The funding mechanisms were then adapting to the governance systems with the implementation of the SUS along the 1990s and the 2000s, with decentralization of federal funds together with the assumption of responsibilities by the state scopes, but specifically municipal government. I believe Brazil has the most decentralized health system in the world, with over 5,000 municipalities. 70% of our municipalities have less than 20,000 inhabitants, so they are very small, and where we have 30% of Brazilian population living. So these municipalities assumed responsibilities, and we created funding mechanisms to induce was considered to be the most adequate. That is why a baseline was for primary care was created. One was fixed based on the population, and the another component that is variable, that encouraged municipalities to implement that specific model that was defined as being the most adequate in order to carry out all the actions for health and clinic, which was the family health model. When we started allocating more funds and inducing the implementation of the model, we were able to relate decentralization and deduction, and then we were able to scale up and expand family health program at the end of the 1990s and beginning of the 2000s, with 4%. From 4% coverage, we increased it to 60% coverage. So I believe this was a very important arrangement to consolidate this model, and today we have approximately 70% coverage of the Brazilian population, that is 200 million, but with the family health program. Now, in the decentralized and co-financed funding by states and municipalities, we had, with the implementation of this model and the maintenance of an underfunding nationally, we had an overload on the municipalities. So there is a federal induction in this model. Municipalities implemented the model because it was a way to transfer automatically and sustainably of funds to support the implementation of a public policy that for the municipalities was a way of receiving the federal funds. So the municipality would implement the model. However, when the program was being implemented, and it happened with other policies, not only with healthcare, but as they were being implemented and the national funding was not increasing in the needed proportion to ensure the funding of these services, municipalities got overloaded, and municipalities with differences in administrative and technical differences created more inequality in the way that primary care was implemented among the municipalities, and that created this challenge to think about what the role of the national government is in supporting this project, the expansion and qualification of PHC. We started to sophisticate the funding mechanisms, creating new incentives, new teams, new differentials, recognizing the social vulnerability rates in order to differentiate the resources according to the need, but also creating new mechanisms. And the Mais Médicos, More Doctors program was very important because it wasn't enough to just give the funds to the municipalities, because that did not ensure the capacity of the municipality to hire and to allocate the medical professionals in order to expand the teams. But in 2010, 2011, most professional teams did not have qualified or professionals. So then we created that instead of just sending the funds to the municipality, we started hiring and allocating the professionals through the Mais Médicos program. And as our minister said, we have 27,000 doctors in this program in 54,000 family health teams. That is nearly half of the family health teams that can count on these professionals from the Mais Médicos program. So we were able to consolidate this model, also dialoguing with the previous panel that talked about evidences and how important it is. Where we have family health teams, we saw that there were better health rates. We had better coverage, vaccination coverage, better prenatal controls, and that gave legitimacy to this model. But evidence comes later. First, you have the principles. So the principle for building a universal and the system, the political principle, was the great driver for us to be able to implement this model, to the extent that the evidence started to give legitimacy and base for this public policy to be consolidated. And the setbacks, what we saw was a worsening of the health rates before the previous right-wing government that had denialism as an axis for cultural dispute. But we saw a worsening in rates as of 2016, when we had a very rigid fiscal policy that impacted the growth of funding and aggravating the underfunding that we had already observed before that. So we saw a defunding of the health system at the time. At the time, the Minister of Health said that it was impossible to do that, to change the model. But there was this change in principles, and the minister said that we had to build in Brazil a health system according to the budget. So it would be a poor people, a poor system for poor people, and whoever could pay would pay. So that would increase fragmentation and segmentation. So in addition, the change in the funding model, we had incremental also changes, and the very important rupture in the logic of funding. When you stop funding teams, you stop funding the perspective of a universal and comprehensive health, and you put PHC focusing on the certain group that is registered and based on specific indicators. So this change in scope in the work of these family health teams was very important, and it's difficult to revert the impact that it had at the time. When our mission is to look at the population of a certain territory with responsibility, not only the ones that are registered. We need to have a comprehensive care, and not only regarding certain indicators. So this is what we're trying to go back, because that reduced the scope. That was a real setback for us at the time. So now the challenge we have in rebuilding our system is to recover PHC not as the entry door, but that is able to have a debate, a comprehensive debate, and that is not simple. You have to go to the community and dispute there. But you can only do that if the population sees PHC as something that solves the problems and that it is accessible and timely, because if you have to have long waiting lines, then they will not go there. If you have the consultation with a doctor and your problem is not solved, they will not come back. So can only have legitimacy for the cultural dispute if we are able to have an accessible PHC with resolution capacity, and we can only do that if we have teams that are related or associated to the territory that know the population. So we need to have qualification, hiring and retention of these medical professionals. This is key. Even if we're going through a digital transformation process, what will give access to the population is key, that we have a very strong and powerful policy, and that is a challenge that we are facing from the perspective of governance and funding of our health system. So I'll just conclude. I don't want to talk longer, though these challenges that we present. And just one final remark that I forgot to mention, but it is also a very important challenge to the Brazilian health system, is the relationship with the specialized care, and to ensure that PHC has the ability to be accessible and resultant-based, but it has to be integrated to the other levels of care. And President Lula, during the transition, I was able to work with a transition team in the health area. We put forth two great challenges for Brazil, to start thinking about Brazil. First, the recovery of the vaccination coverage and our tradition, and the recovery of all the health programs like the Mais Médicos and others. But the second challenge he put forth was that to advance where SUS has not advanced, and that was to think of the reform as a model for specialized care and hospitals in Brazil. So this challenge is one that we've been working on since the previous minister, and the building a national policy for specialized care with experts that in this program will bring many innovations for us to think about specialized care. However, this has to be integrated with the baseline of healthcare, the core of healthcare, which is PHC, and that is. Thank you very much.
I'm being a bad moderator because I have a passion to listen to the presentations and I'm not limiting your time, but it's very interesting considering the guiding questions to open the mind on the discussions about governance to be considered, and considering the analysis and the structure of the state and also the political decision. So it's very clear, not only through the trajectory of the 35 years from SUS, the One Health System in Brazil, but also it's an opportunity to consider that these processes and this trajectory not necessarily are linear. There are some contradictions, and also I think also part of the dialogue is that we have different conceptions of primary care with different initiatives in each one of these stages, and it seems that it was very interesting, your presentation. Now we have Dr. Zambrano, Vice Minister of Health from Panama, and we had the pleasure to have you in different sessions, but now we would like to hear your comments in a more precise way to discuss the relationship between governance, funding, and the primary health care in the context of Panama. Thank you very much. I have listened all the speeches, and I think that we are on the same way. For example, we took the accountability since 18 months ago, and we are considering the prevention on health. And for us, the primary health care is the way, the strategy, the tool. So that's why I was one of the first one to agree with and to be part of this movement on the primary health care. Panama has consolidated the PHC as one of the main axes on the national policy of health 3635 to empower the governance on the system, establishing a shared vision, belonging and having clear tools in the state. In particular, the budget with some sanitary priorities that are explicit. The country move forward in an advanced budget based on the results with the health sector as a pilot, introducing a structural change. The resources start to be according to the sustainable goals on the primary health care, enabling the facility the put into practice the discourse. And what are we doing? We have been developing some situations that are going on the direction to contribute and to be the tool for the primary health care. We have been implementing electronic shift of social security, and with the Ministry of Health, we have been working on the telemedicine, and we have been working on a platform, RISA, that is management of appointments to decrease the lines to have an appointment with the doctor or the expert. We are working on a budget 26. We are investing almost 500 million designated for the construction and the adequation of the health units that are our places where we can deal in the remote with the population in the remote areas so that we can provide this primary care. We have been having a joint purchase with the Social Security. This plan, I will explain a little bit more about the unification of the system to have better prices, and we are being able really to have an important decrease when we buy and we purchase in a high volume the medication. Also, we have a logistic management on real time using a single place to deal with the critical inputs and considering the management of the inventory that it's being updated. So for that, we are using the expiring date of the medication. All this information is in the system. We have also a program that we are implementing, and this is a system of the medical prescriptions that is inside the system of Social Security, so that this can be sorted and after being registered. I already mentioned the intelligence on the inventory, and we are working also intensively on the decentralization of the oncological services. Because before, all the patients with cancer needed to go to a place like a national oncological bunker, And we are implementing this year another bunker in Davi, in the city of Davi, so that the patients will not need. Since 50 years, we are working with an exercise, but by the end, always it's missing the will, the political will. And I would like to highlight that. I'm talking about the political will because when we are with the Ministry of Health, with a thinking on the left, and the director of the Social Security has a thinking that goes to the right, so we don't have points that can that can unite us. So due to the moment that we are facing, because crisis is opportunity. Last year, we had the restructuring of the Social Security with some pension systems, and you know the issue that this topic is in the world. Last year, we approved the law that will give us the resources that we need to deal this together with all the problems on the health sector, and also considering the Ministry of Health as the leader of this movement. So this integration we are being able to have through the alignment of the Minister Fernando Galindo and Maite Dinomon, and with the support, the unconditional support that the president is giving us, and also it's giving great support to have this integration. So we have been meeting together because we will start to integrate two provinces, Elero dos Santos, and yesterday we had the commission in a high level for the segment with the president level. So, and also the report that the president is requesting for March to talk about the evolution of the integration that we expect to have done in less than 2 years. So these are the points that we are trying to do for the stability of the system and to facilitate that primary healthcare can reach all the patients. Not only to have the medication, it's not only having the services. And I think that there is a concept that we must understand. We are talking about the primary care, and we must think about other tasks that we should do in parallel. But it's not because we have the medication, but we can have the stock of the medication. This is not the point. But it must be where, together with the patient, where the patient is. And who is responsible for that? The responsible for that are institutions that will ensure the public health. So they must ensure that the patient will, that the medication will reach the patient. And how many hypertension people were diagnosed and receive, and they are controlled. So these are reflections that we must do, because not only will be we have something 20-something% that is controlled. The same thing with diabetes. We have around 10% of people that can have diabetes in Panama, and almost 80% even doesn't know that. So this is important, and this will resolve if we are working with a platform gathering information in the primary care. This is the goal that we should work for. So I would like to end my speech, and I would like to really thank PAHO, the World Bank, and IDB that are working together with us hardly, and they are here also. And we are having a lot of meetings to be able to continue with this effort and to have a good outcome. And we should have really an outcome. Thank you very much. Thank you very much, Dr. Sandrano, and for the detailing of your initiatives in your country and to share with us, by sharing with us, a very important challenge that is the process of integrating the system of Social Security, the Institute of Social Security, the ministry, and that in a certain way is an example, an emblematic example on transformation, governance, and funding. Na,
De
agora eu vou falar com o Nestor Center. Doutor Ram Shah e Nancy, tá certo a forma como eu falei? Bom,
Minister of Health of Suriname, please, the floor is yours.
Yep, thank you. Raj Jatnanan Singh, I know it's not a name you will hear every day. Goedemorgen, as we say in Dutch in Suriname. Let me start by giving some background information. I know we are a small country. As an ex-colony of Holland, we speak Dutch. And all the nurses and doctors who are trained in Suriname speak Dutch as well. And why I say this is starting by the difficult part in Suriname now, keeping up the quality of PHC, because of the wage difference between the nurses and doctors in Suriname and in the Dutch-speaking countries like Belgium, Holland, the islands, Aruba, Curaçao. We experience a brain drain, which is affecting, of course, the whole health system as well. But we are very positive. Madam President is a medical doctor. We know that we have to challenge some years before we enter the new industry, the gas and oil industry, where we should have a bit more money to spend on the health system in Suriname. Nowadays, it's 7% of the national budget. 600,000 inhabitants. We have a great deal of the polyclinics is owned by the government itself, divided actually into big groups. The regional health center, the RGD as we call it, and the medical mission, that is especially for the interior. It's only 1/10 of Suriname is inhabited. 9/10 is still jungle and bush, where they still work in the wood sector, and especially also in the gold mining sector. So we need, of course, the health sector in there as well. Okay, Suriname is ongoing. In Suriname, ongoing primary health care, the PSC reforms have increasingly focused on strengthening governance arrangements and aligning financing mechanisms to support more integrated, people-centered service delivery. Key policy directions have emphasized clear stewardship roles of the Ministry of Health, improved coordination across public providers, like I just mentioned, RGG and the medical missions, referral hospitals, and the gradual introduction of digital innovations such as electronic health records, telehealth pilots in interior communities, and improved health information system to support planning and accountability. It would be very difficult for us to maintain the quality of PHC in the interior if we cannot make use of the telehealth center, the telehealth modules again. On the financing side, reforms have aimed at better pooling and strategic purchasing through existing insurance arrangements, greater emphasis on prevention and first-level care to reduce avoidable hospital expenditures, and efforts to align PHC investment with broader health sector reform and universal health coverage objectives. Mentioning the part of prevention, all right, I'll explain that just now in another release. The government in Suriname is now in place for about 7 months, but still we have done some assessment to how to change the health policy that we have now to maybe on a higher level. And some of the changes suggested, I'll name some of them for you here. At the insurance side, we have free for service now. We want to change it to a single payer system. From fragmented funding to a single coordinator, the state health insurance will become the dominant health fund for basic care instead of the parallel and poorly coordinated public and private funding streams. From input-based to result-based funding, this replaces individual procedures and ad hoc declarations to reduce unnecessary spendings on health issues. From a non-binding market to a regulated plurality, private and public providers will continue to exist, but under clear contracting. From a curative focus to strong primary care and prevention, structural investment in family doctors, community care, and public health instead of hospital-driven policy. From political direction to institutional governance, a clear division of roles between policy, the ministry, financing, the state health insurance, supervision, and implementation. From universal access to explicit solidarity, a uniform basic package for everyone with private insurance exclusively for supplementary care. I told you I would say something about the prevention side. As a psychologist, I do spend some time thinking about how to change the mental health issues. We need a lot of prevention still in domestic violence, in substance abuse, suicide attempts. We are very high, the second highest in the region in Caribbean in suicide attempts. If it's 10 persons in Suriname have depression symptoms, it's only 1/10 is seeking help. We have 90% don't seek any help for that. And with that we have, of course, some big problems in the treatment gap. We want to establish a telephone helpline with a referral system for those who cannot come to a psychologist, a psychiatrist, or come to the mental health institution, but we still want to give them the help so they can call and the counselor will talk to them. We're very glad that the image gap training is still going on. If it's up to me, all the teachers and all the health workers should get that training. And we know that the heart initiative is very positive in Suriname, where we saw some good results for that. In summary, less improvisation and fragmentation, more system logic, predictability, and public direction. I think I just mentioned, the most important things.
Thank you very much.
With this presentation, we have a first round where we can understand what is the context of each country, but also what are the innovations that are part of the result of previous processes. And what Jimena said before, to take forward the transformation of this topic of health is not a big bang, and this is something that is not an ideal condition, but we should have this in practice. But it's a process that has a complexity and a political will, and we don't have a lot of time, but this deserve a discussion, and deserve a discussion not only in a theoretical way, but also we must consider each one of the contexts of this panel. And this means that not only we need to build a political decision or a political struggle, but also we need to build some alliances, some coalitions from different types of actors. And also, according to what was mentioned, that is to transform the health system in the logical of the primary health care with legitimacy. It's important to have that, considering the technical, the scientific, and the social scope and the relation with the population. That's why the question that will be the last round now has to do with which type of actors you consider that are fundamental to have some steps on this process to empower the health system together with the primary health care. Jimena, please.
Okay, as mentioned, we have to advance, we have to be able to reach the political will, a political will that transcends government, that is installed as a state principle, and that is considered, that considers that the primary health care is the basic pillar in which the healthcare system is based on. And us as a country, we have tried to conceptualize it as a public asset or a public good, such as the vaccine, and that should be available to all. They should have a specific law that is different than that of hospital workers or workers from the second and third levels, because this favors them in many circumstances, because as was mentioned in different panels, there's this idea that PHC is less attractive for workers, and that is why this law, this norm, should consider several items that are attractive to them, and workers defend that. We have many workers in the municipal level, but also in the non-municipalized health work. For example, at Patagonia, PHC is delivered by the national service and not the municipal because of costs, due to the long distances and the population dispersion. So it is relevant for some sectors, but however, PHC is generally delivered in the municipalities. So these health workers in primary health care are the main group, the main deliverers of health in Chile. And as a minister, I have to deal with the need and try to align the needs and demands, because we are from the public sector, and the public sector is the main employer of the country. No company has the number of employees that we have as government. Chile has 20 million inhabitants and 200,000 workers in hospitals, 100,000 workers in primary health care. So in the hospital associations, we have 17 hospital unions, and in the public health, in the private primary health, we have a very large union with 80,000 workers. So the force, the strength of health workers is very clear. But we also have other actors that are the legislators that express the political work, and their work in working with the authorities, we have to work with all the political parties that are interested in issues related to health care, in both in the House of Representatives and in the Senate, help us defend our interest. The ministry can express its interest, the civil society also, and the health workers, and the legislators. Another very relevant actor are multilateral organizations. The PAHO, the World Bank, the Inter-American Development Bank, and to have this alliance at this time in which these three actors are working together also implies a view towards the same international community, to something that is so important, not only for us who have a specific ideology that defends universality, or who we have the principles of public health that drive us, but also to having these voices that are seen as more technocratic, maybe more economicist. And this is such a virtuous moment where we can establish this alliance where all these different points of view come together in the same direction. It has a very strong relevance in order to implement this transformation agenda towards the well-being of the population. And finally, the academia that filters with their principles and ideas all the different areas, specifically those that are more technical, is also a very important role and must be mobilized in relation to the transformations in the public health agenda. One little thing that I also consider very relevant is that in our case, political will has been driven by the idea that the funding for public health, even though we are a country in which we have a specific budget, it is public health is funded by taxes, especially the PHC, and that is why it should be universal and accessible to all. Thank you very much. Very interesting. Dr. Javier Padilla, thank you very much. I'll be brief. So I don't want to repeat myself, but I would like to say that, or what she said, I say that the population as a key actor also has an element that is related to universality, which is a very important vector, and that is why the primary health care team has also, it should be the place where the rich people are treated, because we have to incorporate the vulnerable populations, but also for it to be really universal, it has to go a level up, including the wealthier. And I also believe that in PHC, we see situations when you see that the professionals are not so attracted to that, and that makes sustainability of them in an activism. When you have workers that stay in PHC, it's seen as activism, but that is not sustainable. The base of PHC should not be that. We have an article that we have never seen transformations in the healthcare industry without the activism of the workers. However, we have to transcend this activism. We have to give PHC a centrality that it deserves with qualified professionals. Also, we have a decentralized systems where you need to have a consensus. Then the technical teams are also very important, because it's to have a consensus on the higher levels, we need to have consensus on the base. So we've reached what we reached when we had different technical teams in the communities, giving their ideas and supported by the people that live there. And as the Chilean minister said, the role of the multilateral organism is very important for us. We work very closely to the WHO, and that gives us international legitimization that also improves our content, what we've been thinking, but also improves our capacity of conveying what we're doing, because we're not, and it shows that we're not isolated in what we're doing. And this is key because there's also has this element of reciprocity. We have a platform. We became a platform of a reference at the WHO. So we have people visiting our country to learn about our PHC, and that shows the workers, gives them more legitimacy and more pride, because they're showing the work we're doing in our country to people from abroad, and that it brings is also it has a symbolic value. Thank you very much. Adriano, your comments and remarks, please. I will not repeat myself, but maybe also include actors that are not traditionally in primary care, but should be. In Brazil, primary care came with the funding from Ministry of Health and the municipalities, and now we need state governments to be included in this agenda. State governments were usually responsible for specialized care, but now in order for us to close the gaps and inequalities and to organize networks for connection with the specialized care to help with the funding of workers, it is important that state governments are also part of primary health care. With regards to health professionals, in addition to the primary care workers, those that work in specialized care must also recognize the role of PHC and interact with PHC. And when you promote this kind of interaction, it's a very powerful thing. I visited Curitiba in 2013 and 2015, and we had interaction mechanisms were created, because those who work in the hospital kind of dequalifies who works with PHC, and those who work with primary health care, they are hesitant to show their fragility. So it is important to create this dialogue. And when it is created, what we see is that 70% of cases are resolved in a space for dialogue that we have called teleregulation, by using technology for discussing cases, and this created a relationship and gave more legitimacy and a sense of belonging to this for a set of principles that the primary health care needs, that are not the traditional ways or what they see. There is a risk of the manager being penalized. And lastly, of course, the population, as everyone already said, the population is key. And I believe that making PHC more accessible and using a mechanism that banks have already used and the supermarkets are using, that is not needing to go to the bank to do financial transactions, or you do not need to go to the supermarket for groceries. So we need this kind of technology to make it even more accessible and more participative. So these are very important mechanisms towards the future.
Any comment, Doctor? The actors, for sure, the population is a fundamental actor, and for this we need to think that the work is a process. It's not overnight that we will convince everyone to believe that this is the pathway. We can have the health team offering the services. We may go with a nurse, with a physician, but if we don't have the awareness of the population that should consider what we are implementing, this will not work. So this is fundamental. But it's important to be the guide. We should be the guide to have this happening. It's important to provide awareness, to consider all the facilities and the communication outlets to ensure that the population will get the benefit of all the ideas of primary care that we are talking here. Another important point is the economical side. We need to add to the Ministry of Finance so that it can really be a support, the economical part, because otherwise we wouldn't have the resources to move forward with the project and we wouldn't be able to do this. And the leadership of the health ministry as an actor, it's clear to articulate the sector and outside the sector, recognizing that the primary care should have an intersectoral governance to approach the social determinants, reducing the fragmentation of the system. And also, considering the previous speech, the process of integrating the Ministry of Health and the Social Security with a president mandate for the recognition that the primary care on health should only can be empowered if it's working together with structures of governance, clear rules of coordination, and the mechanism of funding to overcome the historical fragmentation of our system of health. The health system in Panama, it's been consolidated as a critical space to have national and international actors, including the Panama Organization of Health, the World Bank, the IDB, avoiding the duplication and the transforming the coordinating the actions with impact on the system. So just to summarize, the experience in Panama shows that the primary health care is feasible when the governance and the funding are together with the leadership and political will, with the participation and strategic alliances. Thank you. Thank you. Suriname, please.
Thank you. I have some words to say about the second question as well. I mentioned some of them in the first question, but okay. The feasibility and sustainability of the PHC reforms in Suriname have depended on the engagement of a broad range of actors. Central government, of course, institutions, particularly the Ministry of Health and the Ministry of Finance, have been essential for policy leadership, regulation, and resource allocation. But also the Ministry of Education, the Ministry of Sport should be in this line as well. Public service providers such as RGD clinics and the medical mission have played an important operational role, especially in extending PhD to rural and interior populations. Yesterday, I explained how important the social partnership is with indigenous people. Otherwise, it would be for us in Suriname much more difficult to eliminate malaria from Suriname. Health insurance entities and social security institutions have been important in shaping financing and purchasing arrangements. Development partners including PAHO, WHO, UNICEF, IDB.
Algunas reflexiones finales.
There is a final reflection when we are thinking about the identification of the actors according to your comment. Not only we dispute interests, but also we have different conceptions in this process of transformation, including what was mentioned in the previous session. We are talking about different values. So your kindness by sharing your experience on this way. And I think that we will go to the last moment. So please, a round of applauses for all participants.
Señoras y señores,
Ladies and gentlemen, good afternoon. I kindly ask you to take your seats and to keep your cell phone on mute, please. Ladies and gentlemen, please, I kindly ask you to take your seats and to keep your cell phone on mute. We will start the signature ceremony for the Alliance on the primary health care. We invite to be part of the stage the Executive Secretary from the Ministry of Health Brazil, Mr. Adriano Massuda. Mhm.
a representante
The representative from the World Bank, Mr. Michel Granolati. The representative of the IDB, Mr. Javier Guzman. The Minister of Health, Mr. Daniel Cormi. The Minister of Health from Chile, Mrs. Jimena Aguilera. The Minister of Health from Uruguay, Mrs. Cristina Lustenberg. Minister of Health from Bolivia, Mrs. Marcela Tatiana Flores Zambrana. The Director from PAHO, Mr. Jarbas Barbosa. The Minister of Health from Brazil, Mr. Alexandre Padilha. The purpose of this ceremony is to present the alliance of the APS from Bolivia and Uruguay as a strategic space of coordination between the Ministry of Health, the PAHO, and the IDB and the World Bank. The panel will facilitate the technical coordination and will promote the coherence among the current and the future process, as well as the technical support generating synergy between the national actors to empower the health system in a resilient, equitative, and centered on the primary health care and attentive to the needs of the country. Now, I will pass the floor to the representative of IDP, Mr. Miguel Granolat.
With more comfortable. First of all, I would like to thank the Ministry of Health of Brazil for welcoming us so warmly to such a wonderful place and hosting us in such a warm manner. And of course, thank the rest of the participants for bringing such a spirit of friendship and partnership and commitment to this agenda. It's wonderful to be focusing and be reminding again of how important health is as a human right and as a absolutely fundamental element for a fair functioning of societies, families, and individuals. In the World Bank, there has been some definitions of new priorities with more emphasis on certain goals, and we are very pleased that health has emerged as a priority in terms of working with countries, accompanying countries, supporting countries, learning from countries about how to make progress towards universal health coverage. And of course, we have learned that primary health care remains as the backbone of the strategy to get that. And we have also learned of so much progress and innovation that is happening for that. But health is seen also a fundamental contributor to jobs creation. And jobs are seen as a critical step for helping everybody, especially the more vulnerable people, to be able to express themselves, to develop fully, and to contribute to the society and the economy. And this is mostly for two reasons, because health is a fundamental element of human capital. It's critical for employability and productivity. Thank you very much. I hope you can hear me better. Okay, great. Sorry for that. But also is one of the sectors with the highest potential for job creation. We know how many people are employed in the health sector, and in a region like Latin America, where employment tends to be with high informality and low productivity. Employment in the health sector tends to be more formal, with higher productivity and more stable. So it's good jobs that the health sector can create. So we look forward to continue working with all of you and maybe bring some of this new perspective into the Alliance. Thank you very much.
Passamos a palavra.
We'll pass the floor to the representative of the Inter-American Development Bank, Mr. Javier Guzman. Thank you to our hosts. I also agree that this has been a very productive event, and we have been received with much generosity. So thank you to the Brazilian government, both the federal Brazilian government and the government of Rio de Janeiro. And I would like to thank Barro for being the driver behind this movement. They have called us to collaborate, and we have made strategic alliances, and that shows concrete results now. Thank you also to all the countries which are the reason for our existence, because this exchange has been very sincere, very direct, and very fruitful. I take away three main ideas. The first one is that there is a high level of political commitment with primary health care, and we must capitalize on that. The narrative is essential, as we said that we must forget the idea that the PhD is the entry door, or that the nurse works or doctor work alone. We heard the experiences from Brazil, Spain, and other countries about the way to communicate and what it means to be aligned to this primary health care. And how do we communicate and how do we keep and maintain this high level of political commitment is very important. And we also see how the alliance has grown and matured. It used to be an alliance signed by only 3 institutions. We already have 5 countries in the consulting board, and now 2 more are going to join. So this is a real tool that can contribute importantly to the future. And thirdly is that we still have a lot of work to do. We have advanced in many points. We have learned important lessons. However, the alliance must mature further, but and also show the results. And these results are in coordination on the country level, in the exchange between countries, and on a regional and multilateral level. So this shows the value we all want to see. I leave this meeting very committed, very excited, and I want to thank all of you for this great event, and thank you to my fellow panelists here, because we're closing this event on a high with a very high positive energy, and thank you very much. Now we'll give the floor to the Minister of Health from Uruguay, Ms. Cristina Lutzenberg. Well, for us as Uruguay to sign this commitment, more than signing a document, it may create a commitment as a country. As Javier said, we are going to create advancement indicators. So I don't have much more to add, but to show that our work talks for itself from now on, and to be part of this work board will give us more efficiency, more resolve driven, and better to solve daily problems of people who come to our health system in all of its areas with primary health and all the levels of care. So thank you very much to the whole PAHO system in our region and continent for following the countries in this process, also the World Bank and the IDB, because they help us, support us, solve the problems we have in each of our countries. Thank you very much. At this time, we will pass the floor to the Minister of Health of Bolivia, Ms. Tatiana Flores Zambrano. Good morning, to Mr. Jarbas Barbosa, Director of PAHO, Dr. Michele Gragnolati from the World Bank, Dr. Javier Guzman from the IDB, Mr. Secretary of Health of the Government of Brazil, and my fellow ministers of different countries. It has been an honor to participate in this event that is characterized for being scientific, but also very ethical, because it addresses the conditions of life of the populations in our continent. We have seen and reinforced that PHC is not only a service that is rendered as a peripheral system in the health systems in our countries, but it is a core element in order to improve the quality of life of our populations, and it should be and to become an environment for human resilience. As the Lancet Commission stated, the health systems of the 21st century must shift from a reactive to a more proactive medical practice. In Bolivia, the transition is considered an act of justice and technical robustness. We are also trying to breach gaps and also resolve inequalities. We believe that health is the human right, And the strength of a system is not only in its hospitals, but also in the capacity for treatment.
Muito obrigada, ministra.
Thank you very much, Madam Minister. You can take your seat.
Convidamos
Now we would like to invite the Minister of Uruguay, Ms. Cristina Lustenberg, for signing the document. The representative of the IDB, Mr. Javier Guzman, the representative of the World Bank, Mr. Michele Granilati, the Minister of Health of Brazil, Ms. Cristina Lustenberg, and the Director of PAHO, Mr. Jarbas Barbosa, will sign the document.
Agradecemos ao
We would like to thank the representative of the Inter-American Development Bank, Mr. Javier Guzman, the representative of the World Bank, Mr. Michele Granulati, and the Minister of Health of Uruguay, Ms. Cristina Lustenberg. You may return to your seats. Now we would like to invite for the signing of the intention letter by the Ministry of Health of Brazil, and the Minister of Health of Brazil, Mr. Alexandre Padilha, and the Director of PAHO, Mr. Jarbas Barbosa, to sign the letter of intentions.
Obrigada, ministro.
Thank you, Mr. Minister and Mr. Director. You may return to your seats. And at this time, we would like to give the floor to Dr. Jarbas Barbosa, Representative Director of PAHO. Thank you very much. I have a long speech, but I'll be a little bit more informal. First of all, I would like to thank and acknowledge the Minister of Health of Bolivia, the Minister of Health of Uruguay, my friend Cristina Luxemburg, the Minister of Chile, Dr. Jimena Aguilera, the Minister of San Crispin and Grenadines, Mr. Daniel Cummings, Minister of the Health of Brazil, my friend Alexandre Pandilha. I would like to also thank our partners and allies that from the first moment have been with us in a historic alignment with in the World Bank and from the Inter-American Development Bank, and the PAHO, which took a lesson from the pandemic, the idea that to strengthen and renew and to have a primary health care system that is an important element to ensure the real access to people to universal health care, and that we'll continue to provide all the care needed and during all the health emergencies. We have launched this alliance 2 years ago. Now we have 7 countries, and with Brazil 8 countries that are part of this alliance formally, and we still have 2 other countries that I'm not going to name now because it's a surprise, but we'll have 2 new countries joining us soon, so we will have 10 country members, and by the end of the year I'm sure we'll have even more. We'll have another important opportunity this year because we will have a summit, an Ibero-American summit in Madrid in November, and with the Spanish Ministry of Health, Dr. Monica Eloy, and my colleague from Euro, Hans. We will have a meeting next week in Geneva during the WHO Executive Council in order to coordinate an action and a moment in which the ministries of health of countries of Ibero-America will have universal health and HR as a focus. So we will dialogue in order to prepare for the summit by the end of the year. So this will also be an opportunity to share experiences.
They asked me to take a picture here. I could realize how strong is the participation from the Caribbean countries, and I want to thank the minister and all the vice ministers, CMOs, our colleagues from PAHO that are here. We need to have more countries from the Caribbean joining the alliance. So I think that's very important, your presence here, and I do believe that this event will inspire you, and probably in the next weeks and months we will receive a lot of requests from our brothers and sisters, the ministers of health from the Caribbean countries to join this alliance. The Caribbean countries, they have developed and implemented a very strong primary health care. Now, if we take the elimination of mother-to-child transmission of HIV, we have 80 countries in the Caribbean that have already achieved the elimination. So this is, I think, that's a very strong sign that how strong is the primary health care in the Caribbean, the quality of this primary health care, and I think that with the exchange of different experiences will be very beneficial, not only for countries in Latin America, but also for countries in the Caribbean.
I would also like to thank the Brazilian government on behalf of Minister Alexandre Padilha for being our co-organizer of this event together with our colleagues from the World Bank and the IDB. This is an important moment for exchange of experiences and sharing, and to notice how when we respect the different country contexts and experiences, the efforts become more important in order to make PHC more universal and comprehensive, and at the same time as we solve problems, it becomes the best alternative for people to access specialized services when needed, and this helps us give more efficiency to health spending, especially in a time when countries are going through a reduction in their fiscal and tax spaces and lower budgets. So this is a very effective way to ensure the best results for the health spending and a better impact on people. And I am sure that this is a concrete way to guarantee that the dream of having health for every person in the region, regardless of where they are located, can be reached. So once again, I would like to thank everyone, and on behalf of our co-participants and our members of the Alliance, represented here by Mr. Michele Granolati and the IDB, my colleague Javier Guzman, I would like to thank you for this alliance that is historic, and I believe that other regions in the world should look at us and get inspired and see that financial institutions and health institutions can give this impulse, this boost to advancing universal care. So thank you very much, and let's advance with our alliance. Thank you very much.
Neste momento,
So now we will listen the words from the Health Minister of Brazil, Mr. Alexandre Padilha. Dear friend Jarba Barbosa, is the director of PAHO, Mr. Michel Granolati, representative of the World Bank, Mr. Javier Guzman, representative from IDB, dear colleagues, ministers, vice ministers of health from all countries that are here, my special greetings to all institutions, delegations, the international institutions that are here with us. On behalf of President Lula, Luiz Inácio Lula da Silva, I would like to express my gratitude to all of you that contributed for this debate and for the success of the second regional meeting for the primary health care. In particular, I thank the Foundation Getúlio Vargas, that is the institution that received and hosted us during these days. I don't know if you know, but Alexandre Massuda is professor of this foundation, and I would like to have a special thank for all the workers of the PAHO. Special on behalf of Chris, I would like to greet the office of PAHO in Brazil, our team from the executive secretary from the Ministry of the Health, Bibi, and the secretary of primary health care from the Ministry of Health that is working on this meeting for months. And I would like to thank all for your commitment. So my dear Jarbas, I would like to thank PAHO, but also would like to have you transmitting to Dr. Tedros, the General Director from WHO, all the support from the Brazilian government, in special from the President Lula to WHO. Countries that announce the disattachment from WHO will be the first one that will realize that no one can care about the health of the population in a world where the diseases are circulating over the world and the technologies to deal with this are also circulating. We will only face the global challenge with more cooperation, more empowerment of the multilateral mechanisms, and less isolation among the countries. I would like also to congratulate PAHO, IDB, and the World Bank for the commitment to transform this alliance into an efficient tool that is articulating efforts, promoting cooperation and supporting the Latin American, the Caribbean countries, considering the primary health care as base of this topic. The PHC to transform the health systems is coherent to the challenges that we are facing, the demographic and epidemiological transitions, the effects that are more and more evident on the climate change, on the public health, the social inequalities that are requiring some resilient health system, and with equality as well. It's clear that the PHC strong and integrated means the right of health. Ladies and gentlemen, the primary health care is the more than the entrance door of the system. It's the base of the coordination of the care, the promotion of equity, the reduction of inequalities. In PHC, we create trust with the patients, with the health professionals, the families, and the communities. We can integrate the communities to the system, transforming the reality and the production of life in the territories, empowering the service, providing in a humanized way. In Brazil, SUS, One Health System, has in the primary care the structure pillars as with a network that is all over the territory. It's being fundamental to increase the access to face sanitary emergencies, to deal with chronic diseases, and to respond to the health needs over the life of the citizens. But the government must have the commitment with the primary health care. The numbers of the President Lula shows this commitment. In 2022, the investment in the primary health care in Brazil done by the Ministry of Health was around $7 billion a year, and we have reached in 2025 the investment from the Ministry of Health more than $12 billion a year, with an increase of more than 71% on investments of the primary health care. Also, the investments for the building of units show this commitment. In 2022, the Ministry of Health in Brazil have invested only $30 million for the construction of new units. And we have reached in 2025 the investment of more than $600 million for the construction of new units for primary care in Brazil. And this means concrete deliveries of more than 2,600 units during this period, 800 odontological mobile units, and 10,000 combos of equipment to increase the efficacy on the units. I would like to thank Parro for the program Mais Médicos plus Physicians, literally translating. We know that the challenges for the primary health care is it's providing the availability of physicians. In 2022, this program, Mais Médicos, all over Brazil, that is a program of making available the professionals by the federal government. We had around 15,000 active professionals, and we ended 25 with 27,000 physicians actively working on this program. And at the same time, we still have a lot of room for improvement. We want to improve the quality, the integration of the network, and so digital transformation, the empowerment of the workforce on health, the sustainability on the funding, also transforming the primary health care with the support of the regional and local governments, considering the center of the life production in the territory. This is our strategy, Saúde Brasil 360 graus. The primary care in Brazil is important for the adaptation to the climate changes. That's why in COP30, it was approved the action plan Saúde Belém signed by more than 80 countries and institutions, offering a practical handbook since the surveillance policies based on evidences, innovation on health. All the countries are invited to be part of this plan with the support of WHO and the Alliance for the Transforming Action in the Crime on Health. I try to adapt the goals of climate and health. It's important to have specific allocation of budget and establishing mechanisms of accountability. I thank once more PAHO for supporting us launching our plan of guidelines to build the units resilient to the climate, understanding that empowering the primary care is a condition for more sustainable and equitative systems, as highlighted by the Regional Commission of Lancet for Americas. By the way, in this topic, adaptation to the climate changes, I'd like to take the opportunity that you are in the city of Rio de Janeiro, and I would like to highlight the experience of success from the City Hall of Rio with the integrated operating center. This is an initiative funded by the Ministry of Health with the support of PAHO that is integrating in a smart way the data of the city from the units of health with the data from climate, allowing the issuing of alerts on time for the population, the planning of the units of health, and also offering some important information for the public management. So this coordination between surveillance, monitoring of the climate, urban mobility and territory, this empower the capacity of response from the system, anticipating risk and saving lives. My dear colleagues, ministers, another important factor that affect our countries is the need of empowering the production, innovation on the regional basis of technologies of health, promoting the equitative access. That's why Brazil is leading the global coalition for the local and regional production, and also from G20, launched during the Brazilian presidency of G20 and formalized in May 25 in the last assembly, with the governance implemented in the last meeting of G20 in South Africa. This initiative is based on the international cooperation aiming to improve the access to vaccine, medications, methods of diagnosis, and other tools, also for neglected diseases and people that are vulnerable. And to wrap up, I would like to reaffirm the commitment of the Ministry of Brazil on the primary health care, with structuring access to the universal health and having a central strategy to promote development, equity, and justice. We know that to invest in primary health care is to ensure the right to health through an inclusive and sustainable system. We will keep supporting the alliance between PAHO, the World Bank, the IDB. We are very happy to have signed it today with the presence and the incorporation, the formal incorporation of Brazil. Would like to thank our advisory for international affairs with the final data to have this formal integration to ensure this alliance as a space of integration to transform the system in the region. Lastly, I hope that you had the opportunity to enjoy the landscape of Rio. And by the way, Carnival already started in Rio. If you want to stay more here, there is a lot to do. You can go to different places. Paulo Gus can guide you on the good Carnival in Rio because he has a lot of experience with our Carnival. And also I need to mention a special greeting to the City Hall of Rio de Janeiro, the Municipal Secretary of Health, with the participation on this second regional meeting, organizing some field visits to the units of health, sharing the well-succeed experiences with our colleagues from Latin America and Caribbean. Thank you very much, everyone. Thank you, the authorities, and we invite you to stand for an official photo, please. Let's take a photo now, please.
Nesse momento,
We would like to now invite the authorities to remain on the stage to receive a small memento from the Ministry of Brazil.
em seguida,
Now we would like to invite the vice ministers to receive the gift from the Ministry of Health of Brazil. Mr. Deputy Ministers.
em seguida convidamos aos
We would like to call the vice or deputy ministers to receive a gift from the Ministry of Health of Brazil, please.
chamamos ao palco também.
We would also like to invite Mr. James Fitzgerald and Mr. Christian Morales to the stage.
Convidamos também
We would also like to invite the state secretaries and municipal secretaries to the stage.
Solicitamos, por favor,
We would please kindly ask all participants to remain in the auditorium for an official photograph. And the end, we would like to take an official picture with all participants here in the auditorium, please.
solicitamos,
We would like to please ask all participants to remain in the auditorium for our official photo of the event.
solicitamos, por favor, que os participantes
We would please like to ask all participants to remain in the audience so that we can take the official picture.
solicitamos, por favor,
Would please like to ask participants to please stand in the middle of the audience seats so that we can take the picture.
Okay, guys. Em português. Alguém traduz.
Okay, so we're gonna take the picture. I would like to ask anyone who wants to be in the picture, please stay from this staircase or these stairs, just in the middle section of the audience, please. And then everyone can leave and have lunch after that.
declaramos en
We declare this our event ended, concluded. Thank you very much, and we wish you all a very good afternoon.